Hello and welcome to the RCMchat podcast brought to you by AGS Health. I'm your host, Michelle Dawn Mooney, and today we're talking about denial management. I have two great guests I'm about to bring on to talk about that topic. Today, we have Matthew Bridge, who is the Senior Vice President of Patient Access and AR Service Lines, and Erica Franko, who is Senior Vice President of Customer Success. Thank you both for joining me today.
Thanks, Michelle.
Yeah, thanks, Michelle. Happy to be here.
Happy to have you here. So before we get into it, can we have you give a brief background of what you do for the company and just kind of a few lines about your professional background? Erica, starting with you.
Sure. So I joined AGS about 18 months ago. My team and I actually cover all of our current clients from an account management perspective. I like to say that we're professional problem solvers. So we try to dig deep into what our clients actually need in order to be able to continue on in their business. So I spent most of my career in consulting with Accenture, really focused on the patient access space and patient engagement and experience. So I'm excited to bring that sort of bend to AGS Health.
And you, Matt.
Sure. So Matt Bridge here, based out of Boston. I joined AGS recently, just at the turn of the calendar year in January. And so my role as SVP of Access and AR Service Lines is to really focus on our FY27 strategy, while also being a subject matter expert in support of sales, operations, marketing, and other business units specific to patient access and AR. My background, so I come from a professional services side, so worked at KPMG, helped develop their revenue cycle practice. And prior to that was at Huron Consulting Group out of Chicago.
Perfect. So we are talking about denial management. So let's start off with this. Are denials trending up or down? And any ideas why, depending on what your answer is for the first part of that question?
Sure. I'll go first, Erica, and obviously jump in here. So, yeah, I think it's quite clear, and all the data proves that denials are increasing. And it's been on an upward trajectory here for a number of years. I think there's been some recent publications that it's about a 25% increase in the last 5 or 6 years. And that's also been, we've seen increases since COVID as well, about 10 to 12% increase in denials since COVID started. I think there's a myriad of reasons as to why that's happening. But in general, with volumes down across the board, elective procedures getting canceled, we've seen payers really tighten their belts on what they're reimbursing and having more stringent requirements to achieve payment for our providers, in this post-COVID world.
And I'll take maybe a little bit more of a cynical viewpoint on that, but I agree with Matt. And also, I think this is coming down to a case of misaligned incentives. So we have a for-profit payer whose best interest is to keep all of their premium dollars within the payer system in order to serve their shareholders. And then we have the not-for-profit health systems who are in the business of not only serving patients, but also making money in order to be able to serve those patients. And so their best interest and also with working with AGS is to get reimbursed for those services. So, I think we have sort of a misaligned incentive model here, which is, really kind of germane to the U.S. healthcare system. But something I think that, as Matt mentioned, over COVID and some of the factors there have exacerbated that to the point where we are today.
Yeah. The payers will make their margins no matter what, right?
Yeah.
And they'll get creative, and they can't
Right.
admit that, but that is the reality today, and that just puts the burden back on the provider. And it's a very laborious process to check all those boxes to achieve reimbursement. And that's an area where we can come in and help either provide technology solutions or individuals offshore that can help support those operations.
So we've established that there definitely is an increase that we're seeing in denials. Let me ask you this. What are the more common causes, would you say, for denials that you've encountered?
Sure. I think, metrics vary, but around 50% of all denials are from the patient access or financial clearance function, right? And that percentage has held steady for a long time now. It hasn't fluctuated much with the increase in overall denial volumes post-COVID. But a lot of it points to that front end. And at the end of the day, if we're not financially securing or clearing those patients prior to service, that puts the overall reimbursement at tremendous risk, right? So there are different denial types, and there are abilities to overturn some more easily than others. But those front end, those financial clearance related denials, right? Insurance verification, authorization, those are much harder to overturn if those aren't cleared up front. So that's an area where we see about 50% or the majority of denials stemming from those upstream access functions.
Yeah. And Matt, I'm not sure if you would agree with us or not. I'd be interested to hear it. But, I think that patient access in particular, or financial clearance, I think is relatively new in revenue cycle in terms of area of focus. I think we've spent a lot of time on things like scheduling, we spent a lot of time on coding, on AR services, but things like authorizations, I think a couple of factors go into that. One, the rules are changing all the time. And so, there are several organizations today who have technology on that side. When we dig a little bit deeper into what that technology is, it often has a group of people in the background who are scouring payer websites, who are scouring, governmental websites to actually figure out what are the rules around authorizations, because like I mentioned earlier, they can change on a dime. And so those are being fed into technology systems that hopefully are helping people who are sitting in an office actually process those denials. But I think, we spend a ton of time on things like minimum required data sets, things like that around, the registration of patients. But now I think that we're finding that there are some more complex areas like authorizations that are really driving a lot of these.
Yeah, I would completely agree. And I think to further that point, as the care delivery models evolve over time, right, we're seeing a lot more telehealth offerings. That was a byproduct of COVID. As care models shift into the home away from those, large brick and mortar provider settings, right? I don't want to say it gives payers a creative avenue to deny claims, but I think it adds a layer of complexity, and the rules and regulations change on what's required to secure that account for reimbursement. And I think that's been another factor in this journey related to financial clearance.
And I think, on top of that, I think we're seeing different sort of folks who are providing care, certainly more NPPs and other non-physician practitioners who are actually providing care to patients, which I think adds another layer to that as well, as we look at things like physician shortages, and in particular in sort of rural settings and that sort of thing. And really the burden on the healthcare system to take care of patients who had COVID or related morbidities, things like that.
Yeah. And spurred another thought, Erica. That's a great point. As retail healthcare picks up more and more, right, we're seeing, services being provided out of local pharmacies, CVS, Walgreens, what have you, right? They don't typically have the revenue cycle infrastructure that we would see with a large ambulatory physician practice or an acute facility, right? So they don't have the technology, the standard operating procedures, or the people to secure reimbursement. So, a lot of times those new provider types will sort of either assume wrongly that, they provide care, it gets paid like every other service in the country, right, outside of healthcare. Or that's the cost of doing business, and they don't have the time or energy to staff up to protect their reimbursement. And so it's the cost of doing business. And if they get paid on it, great. But if they don't, so be it, as they kind of, enter into the market. So I think as we see that retail healthcare arm pick up as well, that's another factor in the denial increases.
And I think, not to go down a total tangent here, but I think the interesting part about sort of the emerging sort of retail space is that most of the organizations who got into the retail space expected it to be paid like retail. So it's a cash transaction, higher levels of transparency around, a quick emergency visit is $100 or $120 or something like that. But we're also seeing from patients, I think we've in some sense trained our patients or consumers to expect reimbursement coming from their insurance, generally that's employer sponsored, that they pay into every, paycheck. So, I think there are a lot of factors around that, but we're definitely seeing sort of I think we sort of vacillate depending on the time frame, just to return to that kind of traditional model of fee for service. So I find that to be interesting over time, because I think we go back and forth between value-based care and fee for service, but I think certainly we're kind of edging back towards solidly fee for service with dappling in value-based care.
Yep.
So we're really talking about two problems that organizations are facing. At first, dealing with the existing denials, and then second, preventing them from happening in the future. So let's start off with the first problem of dealing with those existing denials. And we've heard from both of you, laborious to kind of work through that. So what suggestions do you have for organizations struggling with what's become an overwhelming number of denials?
I think one of the interesting things I've been seeing sort of from, the market today is that some organizations are in, no pun intended here, denial of their denial issues. I think that so many of them have this sort of mindset of, and in particular, sort of maybe the smaller health systems, if you will, that, we'll deal with this on the back end. So if something's denied, we can obviously appeal it and have it overturned. And I think that's largely due to resource constraints. So actually understanding the root cause of denials requires some subject matter expertise, but certainly data to be able to uncover where those denials are coming from. And then certainly sort of the political capital, if you will, or the control over systems and processes that allow you to go upstream and make corrections. And so sometimes when we see sort of institutions or organizations that are fragmented, where there's a different leader over sort of the patient access side, or maybe the patient access side currently sits with an individual department, that ability to make sort of influential changes across the revenue cycle becomes limited. And so the realization of, okay, we'll have to wait until something denies to appeal it, I think is something that a lot of organizations are coming to today, which is really unfortunate, because there is, a huge cost burden to actually appealing those denials, whether you do an offshore, outsourced, or even have your own organizational teams that are addressing denials. There's a big cost to that, not just in labor, but also to your overall financial sort of health. So we're seeing things like, delayed reimbursement, your AR days go up, you may get reimbursed eventually. It could be at a lower rate, things like that.
Yeah. And I think what's important to either resolve your open denials and or to prevent them going forward is to understand what's being denied today, right? About 50 to 66% of providers don't even know their denial rate, which is a scary, metric right there. So first and foremost, they need to capture and understand what's denying today, right? In terms of resolving denials, to answer that first part of the question, it really requires alignment between your operating procedures, your technology, right? And having the right complementary resource strategy to work those denials in a timely manner, right? We can't get a denial today and not work it for 6 months, right? We have to have the technology that brings it back for review immediately today. As things deny, the clock starts again, and you have a finite time to appeal that claim. Otherwise, it's dead and you're writing it off, right? So part of it's having that technology. You need to have robust standard operating procedures, predefined appeal templates tailored to the denial reason, tailored to the payer and what they need to overturn the denial. And you need to have appropriate training of your staff. I think outside of the workflows, there's also the managed care piece in holding your payers accountable to what they're denying, right? So again, quantifying what's being denied, comparing that to rules and regulations per your managed care contract, and holding your payers accountable for large denial trends is a critical component while your staff or while your outsourced vendor works those individual denials to overturn them. Right. And I think those are the critical components of staying on top of your denials once they occur. But as Erica mentioned, it is labor intensive, or maybe Michelle, you mentioned that. And so a lot of our clients just don't have the manpower, the people power, if you will, to work those denials as they occur, right? So denials are going up, staffing levels are going down. It creates this black hole where they just can't keep up with it. And so oftentimes it does require a complementary vendor strategy just to keep up with the daily churn of denials as they occur.
So great information with regard to how to handle those existing denials. But let's go to the second part, which, let's try to avoid having the denials in the first place. So how do organizations prevent denials from even happening?
Yeah, I think we touched on that a little bit earlier, but I think to dive a little bit deeper, I think sort of step one is really understanding your revenue cycle and sort of how it's situated within the organization. And that seems, I think like motherhood and apple pie, right? So understanding your revenue cycle, but so often in particular, this is not unique to like a small healthcare system. It's kind of across the board. And in particular, we see it quite a bit in large healthcare systems where we have such a fragmented revenue cycle that sometimes, as Matt mentioned earlier, if 50% of our denials are really coming from a financial clearance type function, which generally happens on the front end, and we actually don't have control from a revenue cycle perspective over those workflows in the front end, then we're kind of set up in the beginning to have challenges. So I've seen things like denials councils that are set up, right? So when we understand where the work is actually happening, we're able to set up councils that say, okay, these are our standard processes. Here's a minimum required data set. Here's how we're handling authorizations. If today it's happening in the practice, and I see this so often where someone's scheduler is actually responsible for obtaining authorizations, which we find in particular here at AGS that it's a specialized function, somewhat because all of the rules, as we mentioned earlier, are changing. But you actually have to have a good understanding of how to use the tools and technology and workflows to actually work through the the authorizations. So, having a denials council, for example, set up where we're able to bridge some of the gaps that we might have in operating model becomes even more essential. But I think step one to all of this is really understanding where your denials are coming from and how to set up a task force in order to tackle those. I mean, we can give some general directions, sort of, you're either really looking at some of the financial clearance functions, you're looking at coding denials. Those are generally, I think, I don't know, Matt, your take on this, but that encompasses probably 75 to 80% of all denials are coming from one of those functions. You can kind of get a sense of it, but I think it requires a deeper dive and certainly more understanding of the analytics that are coming from it, but also sort of your overall process flow.
Yeah. Yeah, and completely agree, right? Quantifying the issues is the first step, right? Whether it's through analytics, whether it's through trend identification from folks working the denials, right? That are on the front lines every day, seeing what Blue Cross is denying or Aetna or Medicaid, right? They will in themselves find trends to support those broader analytics. And then to Erica's point, it does require that council or task force with stakeholders across the revenue cycle. The unfortunate answer that no one wants to hear is it is very time consuming to really identify the true root cause of a denial. It often requires account level sampling, which is the last thing our providers and clients want to do or have the time to do. But that is critical to really understand what is causing those denials so we can then develop ways to remedy them and prevent them from happening, whether it's a process change, whether it's a technology change, a change in scope for an individual who might need to focus more in this area than that area, or again, holding payers accountable for denying inappropriately where they should be reimbursing. So I think those are some of the key components there. And a lot of times it just comes down to capacity constraints, right? If you think about a clinical or a case management unit or a utilization review unit that have nurses who are really focused on the patient care at that point in time, the last thing they have time to do in their day, and they'll tell you this, is to then rework a denial that's come through and provide the necessary clinical information to convey that what was done meets a level of care or a medical necessity threshold. So again, a lot of times our clients are looking for outsourced solutions to help overturn those and ideally prevent or identify the underlying root causes to prevent them from happening in the first place.
Any final thoughts as we're wrapping up here?
I think I just want to underscore that some of the discovery piece of denials management is probably one of the most important. And I think that that's the one that I think is usually the hardest to come by for a variety of different reasons. but mostly because I think people are looking at sort of process first instead of outcome first. So I think starting there and really kind of digging into what do we know about our organization? How are we aligned in terms of operating model for revenue cycle, I think becomes really a critical piece of this. I think some of it's thinking like a consultant. So how do I dive in and do a discovery before I jump in and throw interventions, or most typically throw technology at it? I've seen that sort of all the time. We used to call it sort of like sparkly syndrome. So this technology looks really sort of nice and sparkly and exciting, but if you really don't understand your process, your basic operating model, the technology is really not going to do anything for you in the beginning. So some of it's just gathering that knowledge and sort of thinking as a consulting group would, which would be, how do I discover what my organization looks like, how we're aligned, and then using the data to sort of guide some of these interventions.
Yeah, I think final thought for me is really, look, denials are not going anywhere. They will probably continue to increase, right? So I think it's critical that organizations understand that and invest the appropriate resources to overturn and prevent them, right? And it starts with quantifying the issue, but also quantifying the ROI, right? I mean, there is true financial ROI with preventing denials and with overturning them timely, right? Otherwise, you do lead to net revenue leakage or loss. So it's not just quantifying what's happening today, but quantifying the small investment it would take to prevent and overturn these timely, and what that would mean for operating margins going forward. So, I think that's a critical component to garner stakeholder buy-in to make those necessary investments to handle this unfortunate problem.
We covered a lot of territory here, and hopefully a lot of questions answered. If people have more questions or they want to learn more, what's the best way for them to do so?
Yeah, I think reach out to AGS Health, right? We're always available, and we want to help our providers, right? So a very robust website with contact information on there. Could certainly contact me or Erica directly, and we can get you in touch with the right individuals. So would encourage folks to check in on or connect with us on LinkedIn, or take a look at the website and see how we can help you today.
Perfect. Matthew Bridge, Senior Vice President of Patient Access and AR Service Lines for AGS Health, and Erica Franko, Senior Vice President, Customer Success for AGS Health. Thank you both for joining me today and lending your time to this topic. As we heard, it's not going to go anywhere anytime soon. So important that we get that information out there, and this conversation will hopefully keep going. People can go visit the website. So thank you for being here today.
Excellent.
Thanks, Michelle.
Thank you, Michelle.
Happy to be here.
And thank you for joining us and listening or reviewing the RCM chat, brought to you by AGS Health. Of course, you can go to agshealth.com for more information, talking about denial management, much more about that and more on the website there. So please subscribe to the podcast if you'd like to hear more episodes like this. And until then, I want to remind you to keep revving up those revenue cycles. I'm your host, Michelle Dawn Mooney. Hope to see you soon.